So today we have another important topic, and we have two eminent faculties on this field. So first of all, I would like to introduce Dr. Miriam Johnson. So Dr. Miriam Johnson is a professor of palliative medicine at Hull York Medical School, and she's the director of Wolfson Palliative Care Research Center at University of Hull and adjunct professor at University of Technology, Sydney, Australia. And her interests include mechanism and management of breathlessness and the inequalities of palliative care service provision. And people like heart failure and respiratory diseases, she has a special interest. And she do a lot of projects, and this employ a wide range of research methodologies, and has many collaborative partners from different disciplines and countries. And you will see many articles on breathlessness by Professor Miriam Johnson. So we have a person who did a lot of research in breathlessness. So welcome, Dr. Miriam Johnson, and it's our privilege to have you with us today. Another person from India is Dr. Rajam Iyer, and she's a pulmonologist who has almost 22 years of experience in the field of pulmonology. But she is practicing pulmonology as well as palliative care, and in Mumbai, both Bhatia Hospital as well as in Hinduja Hospital. And you might have seen her in various forums, and she has led many pulmonologists into the field of palliative care. Thank you, Dr. Rajam Iyer, and
thank you,
Professor Miriam Johnson, for being with us today. So it's over to you.
Well, I think I'm first on the bill, so I'll crack on if that's all right, Dr. Iyer.
Absolutely.
So lovely to be with you all. It's the afternoon for me. It's a beautiful sunny afternoon in the UK. We've had more sunshine the last 2 months than we know what to do with. We're all terribly shocked. We don't normally see the sun in the summer. So I'm going to talk to you almost completely about non-cancer respiratory disease to try and get you thinking a little bit about how we might extend your skills into this side of respiratory disease. So I'm going to share my screen and we'll get cracking with the presentation. So I hope you can see slide view. Can somebody wave at me or shout?
Yes.
That's lovely. Okay, so this picture is one that is part of an exhibition that one of my researchers has done, working with patients with non-malignant causes of breathlessness and local artists and local sound engineers. And she's created an exhibition where she's tried to express the distress of living with daily breathlessness. And if you ever want to have a little look at our website, you can see some more of the pictures and recordings that they did for this. And, you know, this is the everyday experience of somebody living with breathlessness. The thought of just getting upstairs is a major undertaking. So that's just by way of a little bit of introduction. So what I just want to, this is, you will know this, but I still think it's worthwhile reminding ourselves about what palliative care is. And I know that certainly there is the extension as well to include palliative care for people living with serious illness, as well as those who are thinking or approaching death. So palliative care, an approach that improves the quality of life, provides relief of suffering by means of an impeccable assessment and treatment of pain and other problems in all domains of people's life. It aims to help people live as actively as possible till death. So this isn't just about the moment of death or just a few days before. This is about living well until you die, living well for as long as you can. It uses a team approach, and it's applicable early on in the course of the illness, in some illnesses right from diagnosis, in conjunction with other therapies that are intended to prolong life. So I can hear people say, well, I know this. So my challenge for my talk to the rest of you is but do you apply this to your patients with COPD, interstitial lung disease, bronchiectasis, cystic fibrosis, as well as those with cancer? So why is palliative care important for people with non-cancer respiratory disease? Well, firstly, because they're really symptomatic, and they're symptomatic for a long time. And during this long time of managing symptoms, they don't get the equivalent access to support or symptom relief as people with cancer often do. Because the primary symptom as well in respiratory diseases is breathlessness. Breathlessness is associated with reduced quality of life, poor mental and physical health, dependence on healthcare services, a really significant family caregiver burden, social isolation, reduced role in society, workforce participation. So although my part in the talk is really thinking about from my own perspective, from my culture, you can imagine what a big impact this will be perhaps for patients you're dealing with in your culture. What if the mother has become sick with breathlessness? She can no longer do the household duties, care for the family. Might the daughter have to come and stop her education to help around the house? What if the father can no longer manage to do his work? Does the son have to stop his education? Big implications on family role, income, poverty, and education. So how do I say they've got the same symptom burdens? Well, Claudia Valsvein's team did this lovely cross-sectional study, just asking patients about their symptoms and concerns. So they used the Memorial Symptom Assessment Scale, and they had a group of cancer patients and a group of patients with COPD. And you can see on the right there that these symptoms are pretty equivalent, give or take, for both groups of patients. The median number of symptoms was the same for both groups. The distress score was about the same for both groups, but look at the survival. The median survival for cancer patients was 107 days versus 589 days, people living with this sort of symptom burden. So my conclusion from this paper is that people with non-malignant respiratory disease, such as COPD, may live with the same burden as people with lung cancer, but nearly 6 times as long. It's also symptoms in non-cancer symptom respiratory disease is also often completely invisible. Here is a neat study that some Swedish colleagues did. This was a randomized controlled trial, which was a scenario-based trial. So this was emailed to participating respiratory physicians, and it started off with a scenario of somebody with severe COPD, who was being optimally treated. So they'd had their smoking cessation, they'd had all their triple inhalation therapy, they had vaccination, they'd had pulmonary rehabilitation, and this is where the trial differed in the randomization. So one group were randomized to a scenario where at follow-up, severe breathlessness, and the other group were randomized to a patient who had pain, markedly restricting daily activities, unchanged for at least 3 months. They were taking paracetamol, they were allergic to non-steroidals. So this is the scenario. So this isn't somebody with a little twinge or a bit out of puff. This is somebody living with severe symptom that is restricting their daily activities, which has been going on for at least 3 months. The question these respiratory physicians were asked to complete was, does this patient need further treatment? And if so, what type of treatment? Here are the findings. So if we look at the blue side, the patient with a scenario of chronic breathlessness, only 10% would have been offered further treatment. And only 5% would have been offered symptomatic treatment, and an even smaller percentage would anyone have thought perhaps about low-dose oral opioids. I mean, the pain is a lot better, but it's still a little bit worrying, isn't it? That this person with severe pain, only 30% of the respiratory physicians thought that they might need to do something about it. So are these symptoms invisible to the clinicians? I suspect that for many patients with non-cancer conditions, it is. How does the UK respond to this? So that was a Swedish study. What about the UK? Well, Here was a study looking at data collected from real-life patients attending their GPs. There is a clinical practice research database in the UK which sucks in real-life data from a wide range of GP practices up and down the country. And this research team looked for codes from the data that indicated either general or specialist palliative care had been provided for this patient. And they found that only 6% of COPD patients, compared with half COPD patients who also had lung cancer, had been provided with palliative care. And you can see how this changes over time. So things are improving a little bit, but still not brilliant in terms of the percentage of people receiving palliative care. And if they so lung cancer, having lung cancer on top of the COPD, patients with lung cancer too were nearly 15 times more likely to receive palliative care. And in decadence, so people who had died with palliative care, COPD versus COPD and lung cancer predicted late palliative care. So those people with COPD alone who did receive palliative care, it was very, very late in their disease trajectory, which, as I've just shown you, these people are living with massive symptom burden, sometimes for years. So the study confirmed that there's only about 21 COPD decadents with evidence. So confirmed previous work showing only about a fifth of COPD decadents had actually had evidence of palliative care, and again, very, very late, just within a month of death. That was another study that had been done in 2019 as well. So what about barriers? What sort of barriers do we have to overcome? Well, people talk about the uncertain disease trajectory in non-cancer respiratory disease. And it's a difficult one. And yeah, I would actually like to challenge you listening today. Is this just something we trot out because we think it's a really good excuse for us not recognizing when somebody is going to die? Why is their disease trajectory any different from somebody who has a hematological malignancy who may respond to treatment, then they relapse again, they might have a life-threatening neutropenic sepsis but recover. They also have these dips and troughs. What about breast cancer patients who are living with intermittent recurrent disease, next line chemotherapy? During therapy, they may have neutropenic sepsis and other severe life-threatening intercurrent infections. So I do want to challenge you a little bit. Is the uncertain disease trajectory really, really the bottom line reason, or is it an excuse? People say, well, the transition to end-of-life care is unclear. And again, that may be very, very true for cancers as well. Particularly now they've got options for second, third line, fourth line, targeted immunotherapies, which can continue right up to the point of death. So if palliative care is only thought of something which is the end of the line, if it's only thought of something that can be delivered once all active treatments have been thought of, tried and stopped because they're proving to be no use, then of course, many patients with cancer will never get palliative care, and almost nobody in people with non-cancer respiratory disease will get palliative care. However, I think there's another issue with COPD. I think patients get so used to living with the symptoms and the COPD that they're it becomes normal. Well, of course, I'm breathless, I've got COPD. And I would say this becomes the same mindset in the clinician. Well, of course they're breathless, they've got COPD, of course they can't do much, they've got COPD, of course they've had to stop work, they've got COPD. And nobody is thinking whether there could be additional support or needs or addressing their symptoms. And I think there is a big lack of professional awareness of the potential role of palliative care in people with non-cancer diseases. And then on top of that, you have again this issue about the word. Patients' perceived association of palliative care is cancer or dead now, the last few days. It is the end of the line. And as clinicians, we have a really big mountain to climb to try and get that public narrative in the public, and also with the individual patient sitting in the clinic room with us, that actually, we can work alongside palliative care team members as an extended part of our team. This is not either or, and this is not, are we there yet? This is something that we can embrace according to the needs of the patient. So the old phrase of, well, they're not palliative yet, or the patient saying, I'm not palliative yet. We have a big job on our hands to try and change perceptions and understandings of this word. There's been calls to change the word to supportive care. I'm very practical. I think whatever works in your situation, but I would just say this point of warning: if we change the word but not the understanding, we will be in the same place. The new word will take on the old meaning. Let me give you an example. Back in the 1970s in Canada, Balfour Mount suggested that we should change the word hospice care to palliative care because people viewed hospice as being just the last days of life. Well, we changed the word to palliative care, but the misunderstanding lives on. So I think we have a big role, particularly as clinicians, to model this good, if you like, good behavior with patients, that the word, if we clearly don't treat the word palliative as just being the last day of life, then that can give them confidence that this is about helping them to live as long as they can, as well as they can. So how might we overcome some of these barriers? And I would suggest the key to this moves from when, like, are we there yet, to what and how. So one of the pieces of work we've been doing with the European Respiratory Society is looking about how to try and do this. And the thing that keeps coming up again and again is earlier introduction to palliative care. Now, this doesn't necessarily mean to the palliative care team, but to the concept of palliative care. And this is about focusing on the needs rather than the prognosis. It's not so much as, what do you know, are we nearly dead yet? It's right, what are the problems of today? What are the difficulties you're facing today? Well, you're struggling with the family's really worried about you, you're not sleeping well, you've got some pain. Oh, I think somebody must have their microphone not on mute. It'd be helpful if that would be possible. Thank you.
Rajalakshmi, please unmute the.
Yes, sir. Yes, sir. Dr. Miriam, you can continue.
Thank you. And we need to sort of take this story to help you to live as long as you can for as well as you can. And this breaks that sole meaning of palliative care equals death. Whilst it doesn't deny that we have much to offer for people who are dying, but it extends access both through generalists learning palliative care skills and involving the specialist palliative care team for persistent and severe problems. And if specialist palliative care is required, I would suggest the challenge to the specialist palliative care team is that once the particular issues are addressed, then they should discharge their patient. They should not be held to their bosom until death do they part, because then their service becomes full of people who really don't need them, and that their usual care team can manage them. And then should there be problems coming up again in the future, then they can be referred back to the service. So how, again, focusing on the what and how do we do it rather than when. If we're looking at holistic needs assessments to identify those with persistent symptoms and concerns, this focuses on the needs. And by taking the, if you like, the bull by the horns ourselves as a clinician, rather than waiting for the patient to bring their worries to us, it breaks the don't ask, don't tell, because what happens is the patients have just got used to this with their life. They don't know what we need to know. They don't know what we might be able to help with. So, and they're thinking, well, if there's a problem, then the doctor will be asking me. The doctor thinks, well, if they're worried, they'd be telling me, but no, they won't. It is the doctor and the nurse's responsibility to find out actively what the symptoms and concerns of the patient is. In the UK, in GP land, we've got a particular problem with, it's such a tight time frame. It's about 10 minutes at least, well, at most. And these people who often have complex problems have to choose, well, you can only talk about one problem in this visit. And so patients experience breathlessness and other symptoms in amongst lots of other issues. And so they have to try and divine which is the one that the doctor wants to hear about and what they might be able to do. So there's often a whole pile of other stuff which the patient has not brought to that consultation. This approach also then allows the multidisciplinary team to really get into action, because if you can then find out then that they've got some physiotherapy problems. If you don't ask, you're not going to find out, and the patient may not be able to refer to the team member who could really help. It also validates the patient experience, and they're more likely to come back and say, I've still got this particular issue, or I've now got something else. A key thing in the how do we overcome barriers is communication across healthcare settings in a coordinated and regular manner so that patients don't fall between the stools of the hospital care and the stools of community care. And that is challenging in my healthcare setting. And I imagine it's a very challenging problem in your healthcare setting. For respiratory physicians, working with their palliative care colleagues is a really good way of both teams really learning about the conditions, supporting each other, and increasing each other's skills. So a couple of things to consider. Now, in the UK, 75% of people presenting to the emergency department by ambulance had acute on chronic breathlessness. They said they did manage to talk to their GP about it. So that's a potential role for primary care, particularly in the UK, to help in this situation. I'm aware it's not the same model for you in India. But we've also been looking at who older adults with frailty and breathlessness talk to clinically, and only about 22% of them reported, so these are just people getting on with their lives in the community, only a fifth of them said they went anywhere near their GPs asking about their breathlessness because it's just one problem amongst many. They've got one visit with one problem to prioritise, so the symptoms are not prioritised and it remains hidden. So again, how can we overcome these barriers? Well, we need to be aware of some triggers to make us think about palliative care. We've talked about persistent symptoms and concerns. Other triggers that are flagged up in our healthcare setting are people who are repeatedly pitching up to the hospital to be admitted or to the emergency department, the point at which patients need to go on to long-term oxygen therapy. And then there's this issue of, well, should we be looking for triggers regularly? Like I said, is there a regular holistic assessment going on for these patients by somebody? If not the GP, then who might be able to do that? If most of the care for COPD, for example, is done in the hospital setting, then the hospital team need to have a think, how can we do that? In the UK, most of the COPD care happens in the primary care setting with the GP. Every year they have an annual review where they're supposed to ask patients about their level of breathlessness. And at the moment, if they score 3 or 4, so the most severe levels of breathlessness, they then have to check to see whether the patient has had a pulmonary rehabilitation offer. What if that score of 3 or 4 triggered a holistic needs review, as well as checking whether they'd had pulmonary rehab? Just think how that care for that patient could be completely revolutionized if a healthcare clinician actually asked them about the impact of their symptoms. What's happening in Europe and America and the UK? Well, I mentioned the European Respiratory Society. We're just about to submit our piece of work about palliative care and COPD and ILD, and that has very strong recommendations for what, when, and how of integrating palliative care into routine respiratory care. The American Thoracic Society published their clinical guideline recommending this back in 2008, and it's been embedded in UK guidance for several years. The problem is implementing it into practice, and at the minute it tends to be working well where you have areas where there are enthusiasts, like Dr. Iyer doing fantastic stuff in Mumbai, but she'll tell you that she's not everybody who is doing this. So in summary, for people with non-cancer respiratory disease, their palliative care needs are equivalent to those with lung cancer, but they are living longer and with poorer access to palliative care service support. In the UK, at least, and in countries with universal health systems, primary care is really well placed to address persistent needs and concerns. And in other healthcare settings, then there needs to be some careful thought about how this might happen. Access to palliative care is still driven by cancer, and these patients are unfairly managed. Patients are willing to discuss with primary care and other clinicians, but their needs need to be legitimised and prioritised and indicated and brought up by the clinician. And therefore, a needs-based approach can overcome the barriers placed by a prognostic approach. Working within the team and between teams, particularly across hospital and community settings, really helps provide continuity of care. And I think the take-home message I'd really like to highlight today is the when question. When should we give palliative care? Are we there? Really does need now to go in the bin. And so with that, I'm going to thank you for your attention. And I think I'm handing back to Dr. Iyer, I think.
Sunil, are we having a discussion of Professor Johnson's talk?
No, I think let's have your presentation and then we will
Okay.
towards.
Okay, fine. Great. Thank you, Professor Johnson. It's always lovely to hear you. And when I know we are talking to a bunch of people who are already trained in palliative care. And when I hear Professor Johnson talking about how in England, they are still, there are issues, almost all the publications which she showed and which she has published and which I will be showing are from the West, and still there is a lot of lack of integration of palliative care in non-malignant, and the whole concept of the fact that we keep segregating this cancer palliative and non-cancer palliative. I think it's time for us to dissolve this difference, and we should really focus on how we can give palliative care to all those who need palliative care. And that's what Professor Johnson very nicely said, that we really need to focus, since palliative care is a need-based service. It should not be specifically to when, but it really depends on how much the patient needs to. So today, taking from this, what we have realized in my practice, in the past 3 to 4 years of practicing as a respiratory palliative care, is when we actually tell the general practitioners or other palliative care physicians who have been trained in or constantly are dealing with cancer patients, is the nitty-gritty of the various illnesses that we see in respiratory medicine. So I thought I'll focus a little bit on how we could handle that and then take it from there. So today I will focus on how we can, sorry, 1 minute. So is that on slide mode? Yeah.
Yes, ma'am.
Yeah. So just coming down to one of my favorite slides, again, I think just continuing with where Professor Johnson left, is in India, we must realize the number of people who do have a chronic non-communicable, or in other words, you can say as non-cancer diseases. The bulk adds up to close to 40 to 50% of people who suffer from hypertension, diabetes, heart disease, stroke, respiratory diseases, and unfortunately TB. So all these conditions, if you realize, are controllable conditions. They're not curable, and they do have a trajectory which is in and out of hospitals or in and out of doctor visits. And like Professor Johnson said very clearly, of how our non-communicable disease patients, or those patients with chronic illnesses, live for a prolonged period of time with high symptom burden and yet do not have their needs assessed. While in cancer, somehow being an emotional diagnosis, or with the fact that patients already think of the fact that they're going to die, the address, and historically, since palliative care was started for cancer patients, somehow that whole concept that palliative care is meant for end of life and palliative care is meant for cancer still sticks on, unfortunately, even amongst doctors. Therefore, the biggest obstacles I face is poor referral from hospital consultants. They just don't think it is time for palliative care, and they also equate palliative care to giving up, and that sends negative connotations to relatives, patients, and the extended society. And if you see the conditions and incidence of the chronic respiratory conditions in India, tuberculosis still is a big burden in this country, especially drug resistance, multi-drug resistant, extra drug resistant, and totally drug resistant tuberculosis. We are seeing patients who are on a constant steady rise. And tuberculosis is not just a social stigma. We still lose 1 person per minute of tuberculosis in the productive age groups between 15 and 49. So it is still sad that an infectious disease like tuberculosis has been made complicated in the country. Patients are not able to afford the difficult treatment. The amount of social stigma, vocational issues, family issues, social issues that the patients face is completely unrecognized and therefore not even addressed. So TB still forms a big chunk of where palliative care can play a huge role and support the patient and family in terms of completing treatment, access to drugs, seeing to it that the family gets rehabilitated following the death of a person who is actually the male breadwinner of the family. Yes, of course, COPD and interstitial lung disease is also on the rise. Please do remember that in India, there is a lot of contribution of indoor pollution, which is because of, pujas, havans, dhoop, agarbatti, poorly ventilated, and also the way we cook. So a lot of the rural part of India still use where not everybody has access to biogas fuel, and they still use, the natural, the wood, and therefore there's a lot of smoke in poorly ventilated houses. And India does contribute to a lot of indoor air pollution, and the deaths due to indoor air pollution, you would have read it, is also on the high, as well as the other big chunk which COVID has complicated, which is the interstitial lung disease. So we do see a lot of patients, especially with hypersensitivity pneumonitis, and a whole lot of progressive fibrosis interstitial lung disease, which are chronic conditions that cannot be cured. Very few patients can afford lung transplant, and they live a life like Dr. Johnson described, of breathlessness daily, 24/7, minute by minute. So again, I think we are still a decade or so behind England and America, or even more, about how to convince our physicians about starting palliative care. This is the one question that helps me start the trigger discussion with other respiratory colleagues. And it is very important to emphasize during your rounds, during your interactions with other colleagues, to think about this. What do you think the patient is? Is the patient going to live? I know this question focuses on when, but this is at least a start point, a mute point, where the West have done research and realized that this is one question that family physicians can ask, so that they can send these patients for palliative care. The other important and sad part of India is the dying, concept of family physicians. We really need them to be the backbone of our healthcare, because they can take palliative care to people's homes. They can give patients palliative care and comforts and supportive care in the houses of patients, because that also directly reflects on the utilization of healthcare resources in our country, financial expenses, because most of them are out of pocket expenses, and at the same time ensure that the patient is comfortable and gets the dignity and respect he or she deserves, especially at end of life. So this is an important question which can be a moot point for you to start a discussion with your colleagues. And there are these documents, which I'm sure all of you have heard of, which is the gold standard framework, as well as the blue maple from Manipal, where clear indicators have been given. So really the respiratory physician or the renal physician, neurologist who looks after MND, rehab, stroke, Parkinson's, gets clear-cut ideas of when you could refer to the patient. And this cannot be spelled out much clearer. So if any two of these criteria are satisfied, this patient needs to get palliative care. And that could be multiple admissions, continuous use of oxygen, and obviously other difficult comorbidities. And this should also include the needs of the patient. So you must realize that we do have clear-cut documentation of criteria for referral, which can be used as a start point for referral. I have just been reading a couple of papers in which also Dr. Miriam's presentation is there, of to how patients with advanced lung diseases suffer much more than that of patients with lung cancer. And they also, because of the unpredictable course, because non-cancer conditions are not perceived as life-limiting compared to cancer, their symptoms are less documented, therefore less treated. These patients end up getting more aggressive treatment at end of life, more CPR, and unfortunately are subjected to life-sustaining treatment. And like Professor Johnson pointed out, since they live longer, there is a caregiver burnout. And in our country, unlike the UK, patients also fall below poverty line, because most patients end up going to private hospitals and spending out of pocket. So this is the two studies which actually show the prevalence of percentage of symptoms in interstitial lung along with lung cancer end of life. And you can see it's almost comparable. So please remember that if we feel, or if the way the historically, patients, families, society, doctors feel that, cancer needs palliative care, we really need to think that a lot of our population suffer from other chronic conditions who experience a lot of symptoms similar to that of lung cancer, and they need our attention too. Also, an interesting first time study which was published about the quality of death and dying in patients with interstitial lung and cancer. And you can see how poorly these patients have access to palliative care, and how these various domains, I've given you the reference. I'm not sure the slide is very clear, but every aspect of quality of death and dying is considered in this particular paper. And you can see how patients with interstitial lung disease do end up suffering with distress and documentation of symptoms much less than that of cancer. So just to run through, all of you know how to evaluate breathlessness, all of you know how to, but the importance is certain investigations which are vital. So one is the blood gas. What we describe as type 1 respiratory failure and type 2 respiratory failure is important in the management of the patient. So those patients who have only reduction of partial pressure of oxygen is type 1 with a normal carbon dioxide on the arterial blood gas. Those patients who have reduction of arterial oxygen as well as a rise in the carbon dioxide are the ones which have type 2 respiratory failure. Obviously, in both these situations, the saturation is less. That's why it is respiratory failure in the first place. Now, it's important to assess these things because we then need to know how to start oxygen, when to start oxygen, and also then advise about NIV. And in a group of patients like motor neuron disease, arterial blood gas is a good sensitive way to actually go through the PEG procedure, so that the patient who might end up losing the swallow reflex will have an alternative route to feeding. Now, the other important test, which again is underrated and probably not available easily everywhere, is the pulmonary function test. We need to remember broadly, pulmonary function test gives us rates and volumes and capacities. So please remember, flow rate, when we say forced expiratory volume in 1 second of expiration, is the airway, is a parameter that reflects the airway conditions. So COPD, asthma, bronchiectasis are the conditions which actually reflect to the airway issues, which is flow rates. Volumes and capacities are affected in parenchymal conditions where the lung shrinks, like interstitial lung disease, like post-COVID, and motor neuron disease, where the muscles are paralyzed. So volumes and capacity, so forced vital capacity, and as well as say, residual volume, these are the ones affected in parenchymal and neuromuscular. Why is this important? Again, it gives you the diagnosis, whether it's airway, parenchymal, therefore the treatment, and therefore when you go to see a patient like this at home, you should know what will help and not. For example, bronchodilators in a breathless patient in an interstitial lung is not going to be of use because it's the parenchyma that is affected. The airways are fine. So these are the small things we need to realize when we go to see patients. Also, a drastic fall in lung function test clearly documents the prognosis of the patient. For example, a diffusion capacity, which is very significant in interstitial lung disease because the interstitium is fibrous, the diffusion of oxygen and carbon dioxide is affected. And when the DLCO is reduced, it clearly below the parameter of 35, we then say that this patient is definitely on the slippery slide where active palliative care integration is important. The other important thing is how we use oxygen. Even as palliative care physicians, every breathless patient will not benefit with oxygen. So you need to know the history of the patient. You need to check the saturation. Non-pharmacological, as you all know, is very, very important before you yank up the oxygen. And please remember, in a patient with COPD with type 2 respiratory failure or a neuromuscular patient with type 2 respiratory failure, increasing the oxygen is going to worsen the carbon dioxide. So such patients will not benefit with increasing oxygen. Such patients will benefit with non-invasive ventilator along with low flow of oxygen. Those patients with type 1 respiratory failure will benefit with increasing oxygen after trying the non-pharmacological methods for a patient who is chronically breathless. So please do stop and ask questions if you want me to go slow. Another very important and also much debated issue is non-invasive ventilator. It is used very commonly in India, even during end of life. There's a serious discussion whether it actually improves comfort of the patient or actually makes the patient more uncomfortable. But you must know, as one of the options that you could give caregivers and the patient, if you have tried all other modalities of decreasing the patient's breathlessness and the patient continues to be breathless. So it is commonly used. The best indication is obviously OSA and hyperventilation syndrome, but it can be used in acute and chronic respiratory insufficiency. What NIV does is provides a pneumatic splint. So it delivers positive pressure. It delivers positive pressure with, positive air with the pressure so that the airways remain patent and can take part in respiration. So you do need to realize that it provides a pneumatic splint. It decreases the airway edema and the airway tone is increased because of the mechanoreceptor stimulation. So you must realize that there are two kinds. One is the continuous positive airway pressure and the BiPAP, which is commonly used in patients with type 2 respiratory failure, where the two different pressures are set for inspiration and expiration. So these are the indicators where you can start NIV, but please remember other non-pharmacological as well as all other optimum medical treatment must be given, and you do explain that this is not something that is going to be the cure for the patient, but may help the patient get comfortable. And also in patients who have not given a consent for negative intubation or invasive intubation, this can be a stopgap before you take and have the time to discuss the futility or aggressiveness of life-prolonging treatment. So these are the indicators to start where there is acidosis, where the patient is tachypneic, and obviously getting more and more tired, and there is a paradoxical respiratory pattern. Then these are the absolute contraindications, or obviously respiratory arrest, cardiac arrest, and all the other severe issues around the face. But you must remember that you need to discuss these things before you start NIV so that patients are aware, and if it doesn't benefit the patient, you should be able to stop it. So just wanted to quickly share with you what we did. We just to tell you know the difference we have tried to make in patients with interstitial lung disease. We did a survey sent to about 54 patients who have been diagnosed with interstitial lung and had palliative care in the past 3 years. And just wanted to highlight to you that it is not an easy task to get enrolled to respiratory physician clinics, but when you do, you really manage to do a good job, where we did manage to give at least 77% of patients an active physiotherapy referral so that they could do activities of daily living with less trouble and could do it with little ease. We did manage to prescribe oral morphine for these patients. Almost 80% of our patients received oral morphine. And the good part is that hospital admissions, close to 45% of patients didn't go to hospital in the end of life when they were so breathless. And also the time that we interacted with the patients was a good 8.5 months, which is a lot of time for us to build a rapport, for them to understand where we are coming from and to process and analyze what we actually want to do for our patients. And these kind of comments actually help you strive further. We have a long road ahead. It's very, very difficult to convince each and every respiratory physician the need to integrate. And what we really need to do, therefore, is train palliative care physicians in respiratory medicine, train respiratory physicians in palliative care. There really needs to be a department in every tertiary hospital and training for them in in the undergraduate levels, because we have a long road to go. And if Professor Johnson, keeps saying about how they can do much more in England, we are way behind. So we all need to put our heads together and we really need to strive further. And we are happy to actually, with Pallium India, bring a proper respiratory medicine to palliative care physicians course shortly, so that every nitty-gritty is solved. And when you people look after patients with COPD, interstitial lung, bronchiectasis, or respiratory failure due to motor neuron disease, all of you are equipped to deal with all the modern modern machines, the CPAP, the BiPAP, the concentrator, etc. And that's our aim, which we will be rolling out shortly, thanks to Palliative. Thank you. Any questions or any comments, please do share. And I would also like to ask you your experiences when you deal with patients with chronic breathlessness due to, COPD, interstitial lung, etc., or even your COVID experience, which all of us would have had by now.
Thank you, Dr. Miriam and Dr. Rajam. So the floor is open for discussion now.
I think Meenakshi wants me to show the indications of, so I'll just share that 1 minute. Why am I doing this? Please start with the questions. Until I manage to get the right slide up. What has happened here? Somebody's asked about the morphine dose, Professor Johnson.
Yeah.
So shall I take that one while you're trying to find the right side?
Okay. In your presence, I shouldn't even be opening my mouth about these things.
Well, you've got a lot of on-the-ground experience, Rajam. I think what we're learning over the years is that this is something for people who are very breathless indeed. This is not for people who have, are MMRC 2, 3. This really is for the people who are limited on their day-to-day in their activities of daily living, if not breathless at rest. The original trial in 2002 actually were patients who were breathless at rest. And I think the effect size in the trials coming through is less obvious. And I think part of that is because the trials are including people who are more ambulant. So I think this really isn't a reach for your prescription pad. It's make sure they've had all the non-pharmacological interventions that they've had regularly, supported training with them, using the fan, using pacing, prioritizing, physical activity, encouraging. And there's another question about pulmonary rehab, but I'll give you to take, Rajam. So if you do want to try opioids, first of all, remember it will make people constipated. And if they get constipated, their breathlessness will get worse because it will restrict diaphragmatic excursion. So they must have co-prescription of laxatives. I would start with very low dose and use in steady state. By that, I mean, this isn't something to give the patient to use as and when they might think they might like it. It's something for regular dosing so that right the way through the 24 hours, they have a little something in the brain, if you like, of morphine, just protecting that brain against the incoming signals of breathlessness. So we're lucky, we have very easy access to sustained release preparations. So I would start with 5 milligrams sustained release in the morning and 5 milligrams sustained release in the evening. And I would review after about a week and see how the patient is doing. And it's not necessarily whether their breathing is any better. I want to hear that they're doing more. So sometimes they'll say their breathing is better, but if they're doing more and their breathlessness is no worse, then I would take that as a benefit. If there is no benefit and they're tolerating it, I would then go up to 10 in the morning and 10 on the night. The maximum dose I would go to would be 30 milligrams a day, because the evidence is very strong that if patients have not responded by 30 milligrams a day, then they're not going to. And that's when your tipping point of where the adverse side effects start to outweigh any small benefit that you might have. And they need to be reviewed. They need to be stopped if it's not helping. And you might get that if someone is then starting to be really starting to move really quite well and starting to improve, I would again consider then stopping it. Has the morphine done its job? If they're very sick and it is very much the end of life and they're dying in the next days to weeks, then the consideration is, are they going to keep the oral route or do you need to change to a parenteral route? But I would try very hard to keep the dose low. It's something that's not the front base at all. This is really your backup when you are running out of all the non-pharmacological things to do. I think that summarizes it. Is there anything else that you would add, Rajam?
We only don't have access to sustained release in the city I practice. So we use low dose morphine immediate release, and we rarely need to go up beyond 20, as Professor Johnson said.
But giving it regularly, so it's not sent in the paper.
Yes, yeah. And also reviewing the patients regularly, because there are sometimes patients either don't want to take in, and most of our patients are worried about constipation. And sometimes patients stop on their own, but it's important to review so that if the patient is comfortable and doing more or with easier with less effort, then we actually can think of even scaling it down. But the problem comes to us at end of life. The problem for us we face is end of life patients who are breathless. They don't want to come to hospital. We do not have hospices. Then managing them at home becomes a bit of a challenge, because oral route is then not an option, and getting parenteral morphine is a challenge. So we still struggle with that, and therefore the pharmacological companies win with a patch. So a lot of times they say, why don't we put a patch, because anyway subcut morphine is not available. At least some amount of synthetic opioids will go. And we have a constant struggle because not all our patients can afford the expensive patch. And in a tropical country, the sweating, everybody cannot be in an air condition, and the control over the release of circulating opioids is not in our hand. But it's a constant struggle because all the general physicians in the country are aware of the patch, and nobody will talk about the injectable morphine. So it's a constant battle that we face.
And can I just add about the patch that beware of the dose. So a 25 patch is equivalent to about 40 to 60 milligrams of morphine a day. So you would be thinking of using a matrix patch, not a gel patch. And if you can get hold of the 12s, don't say, I will deny I said this, but if you cut it in half, that gives you equivalent of a 6 patch, which is about the sort of dose that you're wanting. So you really do need to be aware of that dose conversion with a fentanyl patch.
Very important point.
There is a question regarding anxiolytic, role of anxiolytic in COPD.
So I think I can take it and Professor Johnson can add. It also depends on your evaluation. Yes, anxiety can worsen the patient's breathlessness, and it's an important part of your evaluation, which as respiratory physicians, we are never taught. It's important, therefore, to address patients' anxieties, fears, etc. And if you feel the need, we need a counselor on board. It's very, very important because it's natural for patients who are breathless 24/7 to be anxious. So after your assessment, it's important to get a counselor on board and only then consider adding anxiolytics. If patient is on morphine, morphine does manage to act also to decrease the anxiety a bit, because it does work on the work of breathing and reduces the respiratory rate. But it's very important to assess for anxiety for these patients, because it might not even be the breathlessness they're anxious about and a whole lot of other things happening in their life. So therefore a counselor on board definitely helps. Professor Johnson?
I think again, it's that principle of never underestimate the huge impact of, if you like, talking therapies, techniques to reduce anxiety, meditation, yoga, breathing training, all the things that actually I think in an Indian culture, you're in some ways ahead of us over in the UK, where perhaps we've lost some of this real deep understanding of the impact of mind over breathing. So, take advantage of those things. Psychologists, I cannot recommend them enough. Cognitive behavioral therapies, but things that allow patients to feel immediately safe. And if they're having a big going panic, they may not be able to access the cognitive side of their thinking. And so techniques to just bring them down from that panic. Understanding goes a long way, actually. So, cognitive, I'm not poo-pooing that. I think cognitive is actually very, very important. And then and only then you're thinking about pharmacological. We're about halfway through a big European trial of mirtazapine in breathlessness. So watch that space. The feasibility study gave a signal of benefit. However, for sertraline, there was a negative trial. So, it may be something specific about the qualities of mirtazapine. With benzodiazepines, we just genuinely don't know because the studies are all sort of too little, not very high quality, and the Cochrane review was, well, there's no evidence for or against. The worry is that you get a lot of tachyphylaxis, so you end up just tanking up the dose. People fall over, they lose their memories. We've all seen disasters with long-term benzodiazepines. So we used to restrict it very much to a sort of quicker acting for real serious panic on the occasion, and then at the very end of life, if somebody was dying with serious breathlessness distress, to reduce their level of awareness while they were dying using something like midazolam. But that's what I would say with that. Could I just take the cough one very, very quickly while we're there? Just notice that. So yes, very low dose oral morphine will help, may help with cough. There is a placebo-controlled trial with that. There is a new summary. Rajam might remember. I actually got it on a talk that I did for your last thing. There is, I think it's the American Thoracic Society, or if not, it's I think it's the European Respiratory Society. Have just brought out a summary of management of a cough in respiratory diseases.
Yeah.
Particularly interesting in ILD, PPIs, proton pump inhibitors are not helpful. Prokinetics, however, are. So good old-fashioned domperidone, metoclopramide to help with ILD-related cough. There is a new fancy drug out. There's a Lancet trial recently. If you Google Alan Maurice, he was one of the co-authors of a new treatment that seems to be helpful. And then the other thing, again, going back to old remedies, a favorite of my grandmother, menthol. So she used to make us have menthol inhalations when we got a cold, but actually there's science behind it, there's emerging evidence behind it, works on the trip receptors. And so, these things are not to be forgotten. In COPD, inhaled nebulized saline is good both for mucus clearance and breathlessness, and helps relieve morning cough. So some of these very simple remedies are things that are worth thinking about, but proton pump inhibitors probably have had their day, and the evidence is pointing away, but don't forget prokinetics.
So there are two questions on pulmonary rehabilitation and pulmonary exercise.
So I'm happy to take it. Basically, I think just like any neuromuscular or orthopedic issues are always followed by physiotherapy, the role of pulmonary rehab is extremely important in patients with chronic lung diseases. I think it is underserved and not many people refer their patients. It really benefits patients to not just improve their stamina, the respiratory muscle strength, the breathing techniques. It also helps the endorphins, and so emotionally and at a psychological level also it definitely helps, as exercise benefits all of us. The other thing about pulmonary rehab is it goes on for about 8 to 10 weeks, and the patients actually are grouped and meet every other day. So there's a bit of a team exercise, there's a bit of a healthy competition, and patients are assessed and given graded exercises. So depending on how much patients are able to do, their exercises are gradually increased with supervision. Patients are encouraged to do it with exercise, especially if they have a 6-minute walk test, which is showing and documenting a desaturation. So patients on long-term oxygen are asked and encouraged to use oxygen for exercise, because obviously promotes, basically helps the patient perform better. Now, what we aim in patients with advanced lung diseases is that they do activities of daily living with more ease. So, for example, brushing, going to the bathroom, taking a bath, toilet, and like the questions that we really need to ask these patients before we refer is, what have you stopped doing because of your breathlessness? It's not, is your breathlessness better? So automatically the Pandora's box opens about, I'm not able to either play with my grandchild, eat with my family, go to the toilet. And those are the activities which is prioritized. I mean, what is important for the patient that is addressed in the pulmonary rehab. And I really think there are multiple facets of pulmonary rehab which needs to be emphasized. It does keep patients more mobile. It prevents them from recurrent infections. It keeps them out of hospitals, and eventually, even when they are able to do more and more, it really builds their confidence. So along with a multidisciplinary approach where you have the psychologist who deals with their anxiety, you have the medications which keep their pathophysiology under control, you try all the non-pharmacological techniques and the low dose morphine, it really helps the patients to improve quality of life even in an advanced case. So it's very, very important to refer your patients for pulmonary rehab. And the choice of exercises that you need to do for these patients are different, because in interstitial lung disease, we do not recommend certain breathing out techniques. For example, Kapalbhati in yoga is contraindicated in interstitial lung because these people have honeycombing, and the honeycomb lung can rupture and give rise to a pneumothorax. So it's important to understand the pathophysiology and call up the physiotherapist and say, please don't do forced breathing out techniques or forced expiratory techniques. Simple things like pursed lip breathing, creating a flow resistance for the air to go in and go out, helps the peripheral alveoli participate in respiration. So small things like positioning the patient, like bending forward, hunched up, because the shoulder is then used as a fulcrum for all your accessory muscles of respiration. So sometimes patients actually have adapted to these positions on their own. They have automatically realized that hunching up forward helps or propped up helps. So these are the things to actually improve the mechanical advantage of muscles like the diaphragm and the accessory muscles, which use the shoulder as the fulcrum. So you really need to build their upper limb strength so that the shoulder improves and they can use accessory muscles better. So depending on the pathophysiology is when you actually dictate the different kind of exercises. I hope that was helpful. Anything you would like to add, Professor Johnson?
The only thing to add is that I think doctors, and I can say that speaking as a doctor, have a really important role in emphasizing to the patient how important this is. Because so often the physios can feel that the patient doesn't take it seriously. And it has to be emphasized, this is every bit as important as your inhalers, as any tablets that you might be taking, or anything more invasive, just to really get that message across. And patients listen to doctors. You know, sadly, they will listen to all the good and the bad bits that you say, all the things that you make. You know, they will hold you to it, and they will take what you say as really important. So adding to that importance about pulmonary rehab is really key.
So there are two comments regarding NIV, and both of them have told that that they have seen patients are struggling with NIV, and one has pointed out, especially in end of life, it is going to be more distressing. So what's your? They are also asking whether is there any other good methods that is available anywhere.
So I think the problem with NIV, especially in our country, comes because all the respiratory physicians are very keen to use NIV, especially as a stopgap before intubation. NIV works very well when you have a cardiogenic pulmonary edema, when the forced pneumatic splint pushes the fluid out of the lung into the circulation. It really works well in those conditions. In some conditions of COPD with type 2 respiratory failure or MND with type 2 respiratory failure, again, NIV does work well because the patients can be quite drowsy, be quite exhausted, and that's when the NIV works well. I'm not saying it as a blanket for all patients with respiratory distress. Yes, it can be a big barrier because the patient can't talk, patient can't eat, the patient looks, there's a barrier, especially in end of life. In India, again, like I said, not everybody wants the NIV. So if the patient is uncomfortable with NIV, that is the priority. Patient's comfort comes first. If the patient is not comfortable, then we do not recommend NIV. We use other medications. For example, if the patient is anxious, we then start the morphine, midazolam, or add the benzodiazepines to calm the patient. And because it is end of life, then the concept of having normal oxygen, normal carbon dioxide is probably irrelevant. The comfort is the priority, and therefore it is not something that you should use if the patient is uncomfortable. Please restrict your use of NIV to patients with type 2 respiratory failure and those who will clearly benefit from NIV. It's not a blanket for all patients with respiratory distress. So it's something that the call should come from the respiratory physician. But yes, at end of life, we have a say if the patient is uncomfortable to actually remove the NIV and make it more comfortable for the patient and the caregivers.
So there is another question regarding extensive
It's,
pulmonary metastasis.
yes.
Patient has pleural effusion and maintaining 2 liters of oxygen and has saturation of 90. So how judicious should be the tapping and what should be the endpoint?
So if the prognosis of the patient is poor, I don't think we should poke and prod the patient. I don't think the pleural effusion is contributing to so much of the breathlessness as much as everything else. So it's also, so therefore I think comfort comes first. I don't think we should be subjecting to tapping the patient. It all depends on the prognosis. If the patient's prognosis is good, then actually you can give a pigtail so that it's not something that you keep poking and prodding, and therefore the patient can, the fluid will drain at its own. But if the patient has got poor prognosis, I think just address the comfort. I don't think poking and prodding and removing pleural fluid at home is a good idea at all.
Would
you like to add something, Professor Johnson?
I was just saying, I think the key for this is the comment that this patient has extensive metastasis.
Yes.
And often these patients, their lungs are full of cancer. They have a lot of fibrosis. There may be whole pockets also where the effusion may be walled off. And just draining the fluid deals with only a very small percentage of the issues causing the symptom. And it puts the patient to a lot of distress having the procedure done for very, very little benefit. And then it fills up again very, very quickly indeed. So if the underlying lung is pretty good, then I think that's a different matter. If, however, the lung itself is diseased, then I think draining the fluid can be a difficult decision to make, and not necessarily one that will benefit the patient.
So, Dr. Miriam, there is a question regarding carcinoma lung impinging on the rib and causing erosions, and how to manage pain in this type of patients.
I think, Rajam, can you take that first? Because you'll know what treatment options are available in India better than I would, rather than give you an answer.
Sorry, Sunil, can you repeat that? Because I'm trying to get that question, can't see it on the chat.
Few rib impingement and erosions, an inoperable tumor. Can chemo reduce the pain?
Can chemo reduce the pain? I don't think, again, I don't think the rib metastasis will benefit with chemo at all from my experience. But again, I have very limited cancer experience. So,
from
I'll
cancer,
pass it on.
Can I take that?
Yes.
This is Meenakshi, sorry. Hi. So I just wanted to say that if it's definitely rib metastasis, then palliative radiation, 10 cycles would help rather than chemo at that point, because whether the cancer itself is going to be chemosensitive or not, or is it depending on the receptor studies, mutation studies, is going to be for targeted chemotherapy is a different point altogether. But the fastest thing we could do is to start off analgesics based on the WHO step ladder, and also quickly radiate and give bisphosphonates for the bone metastasis.
Thanks, Meenakshi.
I think
there is no TB. There is one question about TB palliative care. There isn't any, unfortunately. We are drawing up some consensus about including how to support patients of tuberculosis with palliative care. So we are still formulating the consensus. We are do not have any place where these patients can be looked after.
Can we move on to patient presentation? And I request Dr. Rajam to see the chats, and there are one or two more questions to be answered.
Okay.
Okay, so I request Dr. Ariba, who is a junior resident in pain and palliative medicine at Share Kashmir Institute of Medical Sciences, to present the patient story. Dr. Ariba?
Yes. Hello, everyone. I'm Dr. Ariba Zahoor, and I'm a junior resident in pain and palliative care at Share Kashmir Institute of Medical Sciences, SORA. The case was of 65 years old male who was a diagnosed case of squamous cell carcinoma stage 4 with left lung collapse. He presented to us with the difficulty in breathing, pain in chest that was radiating towards back, and he was having cough with sputum production. History of illness: 65-year-old male smoker, non-alcoholic, normotensive, normoglycemic, complaining of having difficulty in breathing with chest pain that radiates to back. Pain was moderate. On pain's score, it was 5 out of 10. He also complains of having cough with sputum production, but there is no hemoptysis, and he was also having no family history of such illness. On examination, the vitals were normal except his saturation, that was 91. Respiratory system, bilateral breath sounds were decreased. Left side was also having some crepitation. Rest of the systemic examinations revealed normal findings. Treatment and significant investigation. On bronchoscopy, the endobronchial growth was present at the level of carina and extending into the left main bronchus and causing occlusion of the lumen, suggesting of likely malignant pathology. On histopathology, examination section shows features of well-differentiated squamous cell carcinoma with adenoid cystic pattern. Extensive necrosis was also noted. Markers for ROS1 was negative, ALK D5F3 was also negative, exon for 18, 19, 20, and 21 showed wild type. On CECT chest, heterogeneously enhancing lesion in mesenteric bronchus and left lower lobe bronchus with collapse of left lung field with obliteration of its superior pulmonary vein and mediastinal lymphadenopathy was noted. Signs of endobronchial mass arising from left mesenteric and left lower lobe bronchus was also seen. There was left hydropneumothorax and a right pleural effusion with minimal apical pneumothorax. Also centroacinar emphysema in the right lung was also seen. Now talking about the psychosocial aspects, the patient belongs to a middle income group. His wife was not also working. He has 3 children who were also daily wakers. He had received 3 cycles of tablet paclitaxel plus carboplatin along with dexamethasone 8 mg, after which the patient developed weakness. Presently, he was not fit for the chemotherapy, but we continued him on the corticosteroids. Patient was referred to pain and palliative care for further treatment, where he was put on tablet Durenzo 1 tablet BD, tablet pantoprazole 40 mg before breakfast, and syrup Planocof 2 tablespoons BD. His main concern obviously was disease is progressing in spite of the treatment. Prognosis is bad. Survival is poor considering the progressive nature of the disease. Also the economical difficulties that he was facing. Psychological stress for the patient and his family in dealing with the progressive nature of the disease and prognosis. The summary, a 65-year-old male patient diagnosed with stage 4 left lung carcinoma with collapse. Discussion points: coping up with the prognosis, coping up with the emotional and psychological aspects of the patient and family, economical aspect of continuing the treatment and family expenses, future of his family, and acceptance of the disease. Thank you.
Thank you, Dr. Ariba. Here we have a 65-year-old man with carcinoma of the lung stage 4 disease. And so Dr. Ariba is asking more about psychological coping with the prognosis, family coping. So Dr. Rajam or Dr. Miriam, would you like to take?
You want to start, Dr. Rajam?
Sure. So did see that you had mentioned about the CT scan with central lobar emphysema. Isn't that what you had said? Yeah.
Yes.
Yeah. So I mean, what are the challenges that you faced treating this patient?
While treating the patient, definitely the first thing was the patient was psychologically really like he was upset about the whole thing. He was concerned about his family. He knew that what is going to happen. And since he was the sole earner, his wife was not working at that time. So the whole concern was about definitely accepting the disease first, and then about the pain that the disease was causing him, then the economical issues that he was going to face, because definitely as I mentioned, I didn't actually write it down there in the presentation, his saturation was down. So we were expecting that the saturation will fall below 90 at some point, so he might need domiciliary oxygen. For that also he might have to like uh, the expenses
Right.
are going to be there, the treatment also. We somehow managed that part, the treatment part, but for the oxygen and everything, we had to like fix the things. And then he was also going to share the expenses. So
But
these
do
were
you
the
have access to counselors in the part that in the place that you live? You do.
yes,
You do.
yes, have a counselor there. Yes, he did
Okay.
come.
Okay. And what and do you have access to morphine where you practice?
Yes, we do. But that's why we actually started him on Durenzo. We just wanted to like go through the step ladder. So after that, I remember that he was shifted on morphine, 10 mg, then 20 mg, and then he like died.
So can we come back to the discussion point? Sorry.
Yeah, sure.
Yeah. So, I mean, I think a lot of it is something that a counselor or a psychologist could have made a difference. And I think increasingly we really need to know, especially post COVID, how much an illness can affect the mind, not just of the patient, but also of the caregivers. So I think that's again another beauty of palliative care, that it's not just doctors, it is people from all paramedical, experts, which can contribute and make a difference. And I think that's what one thing I've learned in palliative care about the team, which makes such a big difference. And unfortunately, and most of us in India end up working isolated. For example, I work on my own and I have to keep getting counselors depending on the patient's affordability or the area, or even sometimes find counselors for the patients because it's not something very easily available. So I think that is what is important. And the other thing is, of course, the rehabilitation of the patient. See, that is another concept that I've seen Pallium India do very often, is educating the children, or seeing to that the wife gets a vocation, which probably in some sense is not not easy at all, especially in an urban setting like where I come from. Finding funding for families, etc., and all is a challenge. So I think a counselor's job, just like the physiotherapist, is extremely important in patients with chronic illnesses, and we should use their services more and more. And again, patient rehab, I think a patient will be much more relaxed thinking of end of life if he knows his children and wife and family are going to be cared for.
Yeah, I think I mean, obviously, I don't know the situation in what you're able to access in terms of economic support, but in terms of the general principles of the human parallels with the patient that I would see, the patient that you see, I think for the clinical staff to have the confidence to sit with distress. I think in palliative care, we have this awful tendency of wanting to fix everything, when actually that can almost trigger anger. If you can fix that thing so quickly, well, why haven't I fixed it myself? And actually, not everyone is going to die this beautiful, calm death with a smile on the face and the family all united and supporting each other. And sometimes death is messy, and sometimes the process of getting there is messy. And allowing families to express that distress and to sit with it without trying to fix it, I think is incredibly important, and one of the most difficult things that we do as clinicians. And one reason why I think it's important that this is a team effort, because there will be days where you just need to sit down with a cup of tea with somebody before you go home and say, look, this is what's happened, and can I just check, is there anything else I should be doing, or can you just listen to how I felt? And recognize there are some days you go home and you feel emotionally drained. And those days, perhaps those are the days that you've done really what you need to be doing. You've sat with distress without trying to fix it, without trying to pretend that it's all going to be all right. But the other thing, though, in the distress, in trying to delineate what are the goals, given the situation, what is important to the patient and his family now, and what can be helped with. Because sometimes there are some things that you can support and make happen through that process of distressing honesty, which you would have missed had you joined in a collusion of trying to pretend people it's all right, because that is less distressing for them. So I say, don't be afraid of distress. Recognize that sometimes we can't fix everything. And thirdly, try to identify even that small goal, what's important, to be there with his family, to perhaps liaise with the school that it's all right for the children to be at home for a couple of days, or whatever it is in that particular family situation, I think it is important. And it's about treating the treatable, managing the untreatable. I don't know if that helps at all, but that sort of listening to it, I could think of a number of people that I have walked alongside, if you like, in those few days. And my heart went out to you, because it's a hard thing to do, but thank goodness there are people such as yourselves who will sit with the distress of those individuals, because going through that distress unsupported by a clinical team will be worse.
Yeah. So I think being there for the patient, and even if you can't change the outcome or solve everything, I think just make the journey more comfortable for them. So I think it's very, very important, and I think that really makes a difference in the disease experience for the patient and the caregiver.
Yes. Thank you so much.
Thank you.
So Dr. Ariba, what is Duranzo?
Sorry.
The
What is
Duranzo.
Duranzo?
Oh, it's basically diclofenac plus codeine combination.
Okay.
Sorry.
Yeah.
You come from Kashmir, isn't it?
Yes, ma'am.
Awesome.
So, Dr. Ariba, do you have any more questions?
No, thank you so much.
If not, I think if anybody else have any more questions regarding the session, you can ask now.
I have a question. Can I go?
Yes.
Yeah. So I just want to know, in many of the end of life situations where patients have got lung metastasis or other reasons why they're breathless, I mean non-cancer conditions also. So they somehow feel good when an oxygen mask is slapped on their faces, and the flow of oxygen sort of keeps them going. Now, irrespective of whether the saturation improves, doesn't improve, they want that on. Despite us, saying that proper position, good ventilation, handheld fan, a lot of breeze in the room, they still hang on to that oxygen. And sometimes it's like somebody already mentioned, it's such a task trying to get oxygen in the patient's homes, especially when finances are strained. So what's the position we should take? What should we say to the patient? I mean, because they're not convinced when you tell them that it's not the oxygen that is keeping you alive. It's your, I mean, lung parenchyma, how much ever it's going to, work for you. I mean, somehow they're not convinced at all. They want to latch on to that oxygen. How do we handle this situation?
You've hit the nail on the head. It's a really difficult one for us as well as for you. I would say perhaps this is a little unhelpful, but it's still worth saying. I think prevention is better than cure here, and I think there needs to be a better education amongst clinicians, because I do think clinicians can be a little bit oxygen happy, if I might say. There's certainly a bit of a change of culture over here, with evidence coming through from particularly emergency staff that oxygen levels need to be titrated, and you don't just whack the oxygen in. You can actually do more harm than good. So it is starting to come through general clinicians' approach that they don't just reach for the oxygen. but more education is needed, but that's going to take time. It's not going to help your patient today. And I think it is very much trying. There are some people I don't think you're ever going to convince, but there are a number where you can sit with them, be patient with them. And again, this is where I think really teaching them techniques to bring that level of anxiety down, of managing their anxiety, because it's often an anxiety related issue. You can wean them off oxygen. And I think we've got a moral obligation to do that because of the cost of oxygen. For us, it's an issue that the NHS can't bear the cost because we're all falling to bits with the NHS. When in out-of-pocket health economies, then it's the patient and the families who might bear that cost, and they may not be able to. So it's not an easy answer for you, but I think you've raised a really important issue that we have a collective responsibility as clinicians to prevent, and then to call it what it is, which is often anxiety, feeding their breathlessness, and to tackle it through different issues. And I also am aware there's an issue about a reluctance for cool airflow across the face, but that's basically what you're doing. I think the benefit they may get is firstly psychological, because they're doing something that they feel they have control over and they believe is going to help. But secondly, they are getting stimulation of their air passages and their face with facial cooling and flow receptors. So thank you for raising that. I wish I could give you a quick, oh, you just do this and you'll be fine. I sympathize with you with this problem.
I also think the nursing.
Thank you.
I also think the nursing curriculum needs the training, because even before the doctor reaches, very often the nurse is either arm twisted to start the oxygen, or the caregivers are saying, please put it. So I think there are 2 points which only I would like to add. One is to educate about the 88 and 92 window, that we only if it's below 88 to start the oxygen, and about the injury that the nascent free oxygen radical can cause when you give it unnecessarily. And the third point is learn from what we did during the COVID second wave. There was so much of abuse of oxygen that we lost patients who didn't get hospital beds is one, but who didn't get hospital beds and no oxygen in the hospital. So there was so much of abuse of oxygen that people who really needed it didn't get. And we had so many people who died because of lack of oxygen during the second wave. So I think very important to educate nursing staff, teach them about 88 to 92. And unfortunately now in India, every house has a pulse oximeter, thanks to COVID. So everybody is desperately checking the pulse ox, and those patients who are unwell, they're constantly on it. It's almost like a 24-hour monitoring. So somewhere
It's a menace.
Yes, it's the post-COVID, and it's on. I mean, it costs about 2,000 rupees to 3,000 rupees, the basic one. So it's something that everybody has it in their houses, which is actually increasing the problem.
So we have to train actually the nurses as well as the doctors, and the more common situation is somebody puts on oxygen mask, but the patient keep throwing away the oxygen mask, but the caregiver want to place it again. So that's the most common situation, and we can manage in this situation, because we can tell the caregiver that you can see the distress that patient is expressing, because the mask is unable to communicate and he feels more suffocated. So in layman's language, breathlessness is equal to oxygen. So this is what we have to change. So I think we can go on like this because we have two very eminent faculties, but our time is up. So I would like to thank Dr. Miriam Johnson as well as Dr. Rajam for this beautiful session.